Hi, I'm Beatrice, PhD. What used to be that time of the month is now this time of the month. Welcome to our community, a curated space for everyone going through perimenopause and menopause. A place where we can find support, good laughs, great tips on products, and lots of education on health. There's beauty in aging. Whatever beautiful means to you, this time of the month will help you find it and live it. The content expressed in this time of the month is not intended to be a substitute for medical advice. The views and opinions expressed on this show are those of the speakers. Dr. Kazanczuk, welcome.
Yes. Thank you.
May I call you Dr. K?
Yes, you may.
Great. So I'm going to read your bio
to
start. And I need my glasses because that's what happens when you're past 45. So Dr. K completed her medical training in Ireland and family medicine residency through the United States. So you had some pretty cool experiences abroad.
Yeah, I saw some different perspectives for sure.
And that's going to be awesome as we talk about menopause today. You are passionate about advocating for women's health, which is why you're here. You currently work in your own family practice with women's health and obstetrical care north of Toronto. We live in Barrie, Ontario, but I figure for everyone else who doesn't know where that is, we're north of Toronto. In Canada, of course. You recently became a first-time mother.
Yes, yeah.
Congratulations.
Thank you.
And our viewers can't see her, but your baby's right here with us.
Yeah,
and
she is.
Yeah.
My little sidekick.
Your little sidekick, and I think that's a testament to the, I don't even know if I should call it triple or quadruple burden of so many of us now, right?
That's fair, yeah.
You're a family doctor, so you have your own career, you're a new mom, you have a partner.
Yeah.
And everything else in your life. And so today, there was no sitter for the baby. So she is with us on this time of the month. And we're so happy she's here. So you recently qualified as, is it recently, a breastfeeding specialist? Would you say recent past or?
Yeah, she inspired me while on maternity leave to do some courses. So I'm now a certified breastfeeding specialist. And I hope to become an IBCLC, which is the highest certification for breastfeeding specialty.
I cannot speak highly enough of the support needed. And I received it at St. Joe's Hospital when I was a new mom. And I've never forgotten all the support that I received while I was nursing.
Yeah, it takes a big community, honestly. Yeah.
You would think it's natural.
Right.
And intuitive.
Right.
It is not
so much in practice.
It's not. So that is going to be so helpful to so many new moms. You, on the personal side, like cooking?
I do, yeah.
What's your favorite thing to cook?
Oh, that's a good question. I love Half Baked Harvest. I don't know if you're familiar with
her.
She's got an awesome cooking blog. She's just like lives in the mountains and cooks just very like kind of earthy, organic meals, and they're amazing.
That sounds delicious. You love baking, practicing yoga, which is so good and particularly useful, I think, in perimenopause, at all ages, but perimenopause has been useful, and skiing.
Yes, when I'm not pregnant or on maternity leave or,
Well, today we're going to talk about, and I have menopause brain fog, so that's why I have my cue cards.
Fair enough.
So that I remember what questions to ask you. And I think that my journey, I've stated several times in previous episodes that even though I'm scientifically educated, I have a PhD in biological sciences, it did not enter my consciousness. It wasn't part of any teaching. And as far as I can tell, because I'm married to a physician, it wasn't really part of his medical school education.
Yeah, I'd say that's pretty accurate.
What about your medical school? Because, you're 2 decades younger than my husband and I. So I hope things have changed. So tell me about your med school.
Yeah, honestly, I don't know if I recall, like in medical school, kind of teaching about menopause too much. I don't have a lot of memory about learning about it there. In family medicine training, it definitely comes up for sure, because family medicine, we take care of, everything cradle to grave, as they say. So everything from babies to our elderly patients and everything in between. So, of course, we encounter patients with menopause and throughout the transition. But I would say the challenge with training family doctors, and I can only speak to my own specialty, there's such a breadth of things we have to cover, for the whole lifespan, that it's challenging to really get into depth, about any one topic. So it is challenging to really get into the, deep weeds of menopause when there's so many other things to get trained on and learn. So I'd say we definitely touched on it in training, but maybe not so much to the depth that is needed or that I have needed in my practice.
And, that's important because I don't want to give the medical establishment a bad rap. It's a lot of pressure for a family doctor to understand cradle to grave.
Totally.
In depth.
Yeah.
And so
there's a lot to cover in that time span.
I wonder, if there's an opportunity, how does one then support, your patient base that is going through this? What have you done to deepen your knowledge base with respect to what perimenopause and menopause is, which we'll define in a second for our viewers?
For sure. I think in general in medical training nowadays, we learn that we can't learn everything, all at once in our training. So you learn skills to develop lifelong learning, and you really have to take that upon yourself of learning the particular things that are going to help your patients. So, as I started encountering more and more women in my practice who are experiencing perimenopause and menopause, I just had to take it upon myself to, read research articles, read journal summaries, read guidelines, and personal anecdotes just out of personal interest, read different books and blogs and media things and just try and gain the information to help my patients.
Do you have any favorite resources as a physician where you get your information, up-to-date evidence?
Yeah, in general or on menopause specifically?
On menopause, yeah.
On menopause, there's the Journal of Obstetrics and Gynecology in Canada. So that is our, I would say, primary guidelines for managing gynecologic issues. So that's always a great reference. There's other quick, easy summaries to read. So I use Up to Date, which is a website that, provides kind of quick summaries of current evidence. That's helpful.
So why don't we launch into the how, what, when, and why of perimenopause and menopause. And I want to emphasize the word perimenopause because I didn't even know that word. I just thought of menopause as something that happens somewhere well past 60, maybe even older, something that wasn't going to be part of, my reality for quite some time. And it was very finite in my mind. It was, you're not menopausal and you're menopausal.
And you're menopausal, yeah. I think it's almost portrayed as a single point in time, whereas in reality, it's not.
It is not.
I think the most helpful analogy I heard from a gynecologist I trained with was she described it as climbing a mountain. So you approach the mountain and suddenly, the slope starts to incline and you're experiencing that. All of a sudden, the slope gets very, very steep.
Yes.
Then you reach the top of the mountain at one point, and then you still have a downhill journey. I guess downhill might be a bit of a negative connotation, but to use the mountain analogy, you still have to get over the other side of the mountain too.
All right. So why don't we start with what is perimenopause and what age? Understanding generally what age.
Yeah, for sure. So menopause, like I just described, is a transition and a journey. So there's events that start to happen with people's health as they approach menopause. So if we define menopause as the center point, so menopause is, the last menstrual period, which we don't know until somebody has been without that period for, 1 to 2 years. But perimenopause is the time before that last menstrual period, where women may start having some health changes and some health symptoms. So general time frame, part of what's going on in menopause, which I'm sure we can discuss, is your ovarian reserve, or, very colloquially or generally how many eggs you have left, starts to decrease. So the first event is the viability of the eggs. So how many of those, could go on to develop a healthy child starts to decrease. And that's generally in a woman's early to mid 30s. And then perimenopause, generally for most patients, starts to happen about 5 years before the last menstrual period. So that could be anywhere, it really depends on the age that woman's going to go through menopause, but early 40s to mid 40s Then average age of menopause is about 51, 52. And then there's the postmenopause time, the other side of the mountain as well, and the rest of the life, of course.
And it's amazing because in this day and age, certainly, I'm an example. I sought a higher level of education. And so I was having my children in my mid to late 30s.
Absolutely, yeah.
So what does that overlap look like? Fertility, starting a family, but potentially not even realizing.
Yeah.
Tell me a little bit about that.
Yeah, I think you bring up a great point that women nowadays, there has been a trend, to delay fertility or delay childbearing, for career advancements and things like that. I mean, I was the same. I had to go through medical training and things like that. So it wasn't the time to have children. But, no woman knows, there isn't a way to predict when somebody will go into menopause. And like I talked about, leading up to menopause, there's that time of, decreased egg viability that affects patients' fertility. So we're starting to see an overlap between patients are maybe attempting fertility, heading into their pre-perimenopause or even their perimenopausal years. Or unfortunately for some patients, if they may experience something like premature ovarian failure, where they have, very, very early menopause, and that can be very challenging if they desire fertility.
You just said something that I find very interesting because I think it's perhaps Dr. Jen Gunter, a mutual, person that we look up to. The word ovarian failure. Do we talk about penile failure?
Right. It has a very negative
she says that a lot.
connotation.
And it's so true,
Yeah. I think she said in her book too, like that word failure is attached to so many diagnoses with women's health. Yes. Like I, think of labor where we talk about failure to progress, makes a woman feel like her body's failed.
Yes.
So same with this, term with the ovaries.
And I think that was my struggle, is that I felt as I was experiencing symptoms that I wasn't aware, because we talk about the top three, hot flashes and insomnia and, weight gain. I feel like these may be, at least for those of us who are perhaps aware, but there's many more. And you feel like you're failing, that if you're gaining weight, it's because you're not exercising enough, or if you're not sleeping, it's because your sleep hygiene is horrible.
Right, you're not doing something.
Right, and they are contributors. We definitely know, right, that exercise is good for longevity, period, end of discussion.
Yeah.
Not just through menopause. We know that sleep hygiene is good for physical and mental health. But why does it feel like a failure versus understanding? Like, why is it happening? So, okay, we're starting to produce, less estrogen. So what does that mean? And that goes to I'm going to look at my little notes here, why? Like, why does it happen? Walk us through that.
Yeah, those are great questions. We could get into different levels of depth to it, but, you're talking about an aspect of human evolution in like a very, very broad level. There has been a lot of studies, and this came up as I was doing my breastfeeding certification. It kind of ties in about the power of grandmothers in society. So grandmothers, meaning women who are no longer fertile themselves, they bring a lot to survival, kind of historically with the human species. They bring a lot of knowledge, a lot of resources, and, really help like health rates and survival rates. So
that is fascinating.
It probably evolved out of some form of survival advantage, over time.
I know that just by talking to you, we've met prior to today's episode. We have some mutual connections, and then we met, and I felt so inspired by you. And I feel like every time I talk about perimenopause and menopause, I feel better. It's just the shared, just an opportunity to share. You're not going through it. You're a new mom. Am I allowed to say your age?
Or would I prefer not to.
All right. We won't talk about your age, but you're a new mom.
Yeah.
And I'm on the other side. I have teenagers now, and I am perimenopausal and menopausal. But just the fact that we can share experiences, ask questions, that concept of grandmother is I think it's lost on us, and we have to regain it. And I hope that through that we can change the narrative and not use words like failure or spiraling down, which is what we often feel like. So let's move on to the next question. So yeah, the why, we could go 3 hours on the why menopause happens. How would someone recognize it? Because I think I missed it. I completely missed the signs. Yeah. I was busy.
Yeah.
Building a family in my mid to late 30s, as I've said, building a career, taking care of a household, and everything that comes along with that.
Yep.
Kind of ignoring myself. That's not atypical, right? But I missed it. So what should women, what I wish I knew in my mid 30s as I was raising my family. Yeah. What should I have looked out for? What should our viewers look out for?
Totally. So we can go over some of the common symptoms and things like that. So, most common symptoms to watch out for. So changes in your periods would be a big one. And that's, again, a complex topic because changes in women's periods can happen for a variety of reasons, many not related to menopause. But, there should always be a diagnosis or some attempt to figure out why is that happening. So periods generally approaching menopause. So first, they actually become a little bit shorter. So the follicular phase, the first half of the menstrual cycle before a woman ovulates, tends to shorten first. So women may notice slightly shorter periods. And then as we get closer and closer to menopause, the periods really start to space out. So women will start to go, 2 months, 3 months between periods, or, much longer than that, with or without changes in their bleeding pattern. That can be tricky too, because women may be on contraception as well, which essentially just kind of hides what's going on with their cycle naturally. So you may not get tipped off with your periods if they're controlled by birth control.
That's what happened to me, I guess, now that you're saying it. Because for me, the appearance of it was abrupt. And it's probably because it was masked.
Right.
So for me, I went from, all of a sudden had no period.
Totally. And I want to clarify, it's not a bad thing to be on birth control and, have it mask the symptoms. Some of the symptoms are very unpleasant, like heavy bleeding.
Yes.
And we use contraception as a treatment for that. So it's not a bad thing, but it just makes it more difficult to interpret when you're the woman trying to figure out, what's going on here. And I think we're going to talk about like fertility and, how late can you get pregnant and what's the role of contraception there.
Why don't we go there right now? Might as well. Yeah.
Yeah. And speaking with birth control, there's definitely an overlap between needing contraception and menopause, because essentially, like, until you're, a year to 2 years past your last menstrual period, you can still get pregnant. Doesn't matter if you're like 52, 53, some women are going through menopause not until, if the average age is 51 or 52, some women are below average, some women are above average. So you could have women in their mid-50s who are still fertile. So, if women are not desiring pregnancy, it's really important that they have some form of contraception plan that, is acceptable to them and fits with their life.
Excellent reminder. Are menopausal symptoms cyclical?
Yes, yeah. So, other symptoms like the hot flashes and the sleep disturbances and the bleeding, when we're dealing with the perimenopausal period, perimenopause is characterized by massive hormone fluctuations. So, you may not ovulate for a period of time and skip a couple periods, and the symptoms start to happen, you're getting tons of hot flashes and all this stuff, and then suddenly your ovaries decide one more egg and you ovulate, and suddenly the symptoms are better.
Yeah.
Because you've just, changed the hormonal pattern there. So very much in perimenopause, cyclical for sure.
Some of the symptoms that may not be so obvious or talked about, and I think we're gaining awareness, and that's part of why you're here today. I hope that we really reach more awareness. symptoms like dizziness, things that you may not associate. You might just think, hey, I didn't eat well today, but can you talk about some of the more, what should I call them? Not obscure, just subtle. Symptoms. That's a great word. Subtle symptoms. Yeah.
Yep. I'd say dizziness, mood changes are sometimes not so subtle, big ones, sleep disturbances, changes in hair, like you talked about, changes in body composition.
One of the ones I've
cognitive changes too. You brought up brain fog at the beginning.
Yes, cognitive changes for sure.
Yeah.
And again, I don't want it to sound like all of a sudden we're non-functional beings, because that would be a disservice to people going through it. I feel like I'm at the top of my career game, my knowledge, my experience, but there is this weird brain fog, and it's not for the deep knowledge stuff. I don't know how else to qualify it. It's more like I misplaced the keys to our filing cabinet the other day, and I can't find them.
Yep.
How do I do that? It's these little things that, yeah.
Fortunately for the cognitive changes, it looks like the data says those are temporary in the menopausal transition, and things should go back to your norm.
When will that happen? So that's another question. Yeah. When, how long does this, and I know there's no necessarily one answer, but when will I get my brain fog lifted?
Yeah. We could talk about average times, but then there's women who fall, well outside the average.
Yes, let's talk average time.
Yep. So average perimenopause, 4 to 5 years before the last menstrual period.
Okay.
And, major postmenopausal symptoms a year or two after the last menstrual period. So, a 7-8 year transition overall. But again, that's just average. So for some women, they experience symptoms postmenopause for many years. If we talk hot flashes, 10, 20 years.
That's
for
long.
some portion of women.
So this brings me to one of my pet peeves, okay? Because we talk about it being natural, and it is. It is natural.
Yeah.
But 10 to 20 years?
Yeah, it's a long time.
And our life expectancy is actually extending, right?
Totally.
And so without going deep, because I think that's be the topic of an entirely, you can come back and I think more than once and with more than one expert, the different therapies or supports and tools, because I don't want to I know not everyone can take the same type of or approach, right? Or therapeutic or non-traditional. There's lots of options, but
totally.
What can 10 to 20 years of feeling alone, unsupported,
no, it's not acceptable,
dismissed, that I was told to just live with it or exercise more were my most common answers until I started advocating. And so in fairness, once I started advocating, my husband got on board and was like, okay, we do need to find some solutions. My primary caregiver got on board and took the necessary measures to understand me, my context, and to track me now with my personal journey. But what are some of the general things that we could talk about?
It's a great point. Yeah. I think just because something is natural with our bodies doesn't mean we can't make attempts to change that or improve that. It's about quality of life. Some things that happen with our health, unfortunately, are not good for our quality of life. And that is where there's a role for medicine and a variety of therapies to help us, feel better, live better lives, all those things. Yeah. I think it's most helpful to talk about this like on a symptom basis, because I wouldn't say there's one single therapy that tackles, all symptoms of menopause. It's really depends on what the woman is experiencing.
Okay, so I have some questions from my Estra community. So why don't we tackle some of those, and maybe that's how we can look at some supports, right?
Sure, yeah.
Okay, so I'm gonna look at my questions here. I wake up most nights, sometimes for no reason, and often I have to use the washroom, even when I'm limiting my fluids. Okay, so before bedtime, no fluids. In fact, some start cutting it off earlier and earlier, right? In an attempt to prevent that. And so my Estra community member here says that sleep hygiene is important, but is there anything else she can do to kind of tackle this getting up at night and then having to use the washroom, which is really disruptive.
Totally. Urinary symptoms are pretty common around menopause, and I didn't bring that up earlier, but very common. So our urinary tract, you have to imagine anatomically, is quite close to the reproductive tract. So it is affected by estrogen, the same as our reproductive tract is. So there's definitely effects on the urinary system. So yeah, women will experience, increased frequency. So having to go pee more trouble with bladder control. So finding that they're leaking with coughing or sneezing or things like that. So first of all, the basic bottom line with any symptom is, it's important to start out with a correct diagnosis. So a general theme with menopause is, we should never assume that everything is because of menopause. Just because a woman's in her late 40s and 50s, there could totally be other things going on.
Yeah.
Nor should we ignore that symptoms, aren't necessarily caused by menopause, but there should be some thought as to what's going on with each individual patient and individual symptom. So yeah, first of all would be, visit to the doc to see, okay, what is the diagnosis of, going pee a lot? Does she have a UTI? Does she have kidney stones? Is it the urinary frequency that can be associated with menopause or perimenopause? General treatments there. So we can use vaginal estrogen for urinary symptoms, and that's different than using MHT, kind of full body therapy.
I'm going to pause. Yeah. MHT, a lot of people may not know what that is.
Menopausal hormone therapy. Right. It's the new term that's kind of replaced HRT or hormone replacement therapy.
And I love that because we're not replacing what was lost.
Correct.
It's not about that.
No.
It's menopause hormone therapy. It's different. Okay, keep going.
Yeah. And specifically for urinary symptoms, pelvic floor physio can be very helpful. So pelvic floor physios can do different things like bladder training with patients, Kegel exercises, more complex things to help train their bladders and reduce those symptoms.
Do you think that also part of this bladder training with pelvic exercises, is there any validity? I'm asking because I don't know. Genuinely curious about whether this is valid or not. Once you get in that, I wake up, I have to go pee, I go pee. There's almost this weird loop that happens that now my body wakes up to go pee. Is there a form of training in that, as hard as this may seem, and again, I don't want to induce harm in anyone, and you'll give us your medical expert opinion. I did find that in conjunction with some form of hormone, MHT therapy, but also sort of saying, do you really need to go, and trying to deep breathe and go back to sleep? And then I do, for me, see some benefits there. What have you read, heard, or talked about this with anyone?
Yeah, you're essentially describing CBT in some ways, cognitive behavioral therapy, and that is a useful tool for many symptoms of menopause. So it's useful for insomnia, it's useful for depression, anxiety, it's useful for hot flashes, can be useful in that way that you described to manage bladder symptoms.
That gives us hope.
Yeah.
That's really good to hear, and certainly I think we should talk more about CBT then, because yes, I do think that that's an area where our community would want to hear more, because not everyone wants to take a medicinal intervention. So that's really great. So thank you for answering that question. What's another question? The weight gain.
Yeah.
I wish it wasn't such a topical thing, and it is tied to how we define beauty, I think, in our society. It's really hard to tease out, how deep it goes into our psyche. I think I'm in control of my own standard of beauty. I think that, but am I?
Right.
I don't know. But so why do we gain weight? Even though we might be eating right, we might be exercising, running more than ever, or whatever form of cardio you love. So let's dive there, because it is very bothersome to feel like you're losing your old self despite not really changing your patterns of behavior.
Totally. Yeah. I want to preface, this is a very complex, we could get very, very deep into this discussion.
Yeah.
And I preface any conversation about weight of, understanding that we live in North America in a culture that's very diet culture focused, that there is too much emphasis, placed on, a woman's weight and body size. And ultimately what we know in medicine is a lot of that is not under an individual person's control. So a lot of the studies point to that, weight is largely determined by our genetics, actually, and less determined. There's diet culture makes us think that if we put in more effort, we can achieve a certain outcome with our bodies, and that's actually not necessarily true.
And it's so harsh because then it does perpetuate the feeling of failure.
Exactly. So I think that also remains true in menopause. In general, there are some changes in body composition. So women can experience a loss in muscle mass and, a slightly increase in fat mass, and that may change how their weight is distributed or how their body appears. But again, that, is largely out of their control.
Mm-hmm. That's a tough one.
Mm-hmm.
It is a tough one. You mentioned something about, is there a type of exercise as well, though? Like maybe how we exercise, understanding that genetics is a major contributor and there's things you just can't change.
Yeah.
But the things that we can control, okay, so what, eating, making good choices, our nutrition, good sleep hygiene, and a form of exercise. Is it the same at 20, 30, 40, 50?
Probably not.
Yeah.
Again, I would say, just looking through the lens of this with diet culture, once again, we've been led to believe that if I just find the perfect form of exercise, I can achieve X or Y outcome with my appearance. That is not necessarily the case. You could have two people who have the exact same diet, exact same exercise patterns, and they have completely different body appearances and body sizes. So, I bring this up just to, say with a lot of sensitivity that this is not something, a factor that people can control for the most part. However, in that small little bit that you can manipulate, within what your genetics allows, yeah, if the issue is that you lose muscle over time, weight-bearing exercises would be beneficial and very beneficial to combat osteoporosis or bone loss, which is a huge issue for patients going through the menopausal transition. So I'd say that, never hurts if somebody enjoys that.
But maybe what you're saying also in a different way is we need to be kinder to ourselves.
Absolutely. Yes.
And that hopefully is part of the change in narrative that menopause or just aging, it's okay.
Yeah.
It's okay.
Yes. It's okay to be who you are. It's okay to look what you look like and all those things.
Thank you. I don't know if there's anything else, that maybe, what are the top things you see in your practice?
I'd say the top things I run into, one theme I see is patients not wanting to bring up the symptoms or the subject or kind of being sheepish about how they bring it up. So, I'd say there's a lot of times that I see patients just booking in for a general physical or not something specific. And then it's, when I'm mid pap smear with them or mid listening to their heart, they're like, actually, now that I'm here, can I ask you about this or that symptom? And, there's that, I wonder why didn't they feel comfortable just saying, hey, that's why I'm here. I'm feeling this and I want to know about it, right?
Why do you think that's the case? Why is there that embarrassment? I don't know. Maybe I'm interpreting. Maybe it's not embarrassment. Like, why?
Yeah, that's a great question.
Yeah.
It's probably very individual for patients,
Mm-hmm.
but a number of factors, like you said, there's that societal view or piece that this is natural, we should just deal with it. And, why would you bring it up to your doctor if this is just a normal part of life, right? And the other side is, often the symptoms deal with, intimate parts of anatomy of, our reproductive tract, urinary tract. So those can be hard to bring up, to a doctor.
It can be. I mean, it is the dreaded encounter with a doctor.
Yeah.
Yes. And one thing we haven't even touched upon, and I feel like that's another hour or 10 hours of discussion, and that's, we can perhaps bring up things like, oh, hot flashes, but one thing we don't talk a lot about is some of the things we feel in our reproductive system, right? And so vaginal dryness.
Yes, yeah.
No,
Big
it's
problem.
so taboo.
Yep.
So what happens? What's the difference between, let's talk about the vaginal wall,
Yeah.
pre, peri, and post-menopause. Like, are there anatomical differences?
Absolutely, yeah, for sure.
So tell me about that.
And I think the urinary tract ties into it because it's,
Right.
anatomically very close together. These are very estrogen-sensitive tissues. So you can see, if you examine a patient, at different stages of their life, you can start to see anatomic changes, vaginally and in the urine tract. And these are very common. So I'd say behind, the changes in the periods and the hot flashes, this is up there for, most women are experiencing some level of these changes. So you see generally a loss of elasticity of the tissue. So it's kind of has less like stretch or bounce back, you could say. The vagina has a structure internally called rugae, which are these nice, like healthy, like folds and ripples of tissue that indicates it has, some give and elasticity to it. So when you examine the patient, you see a loss of those rugae, which is, indicating the changes in the tissue. There's changes to the labia. So the labia can become smaller. They can start to fuse at some points. They can become pale, change color. And you can see that kind of all around the perineum. So around the urethra and other areas too.
And I mean, that can cause discomfort just throughout your day.
Yes, yeah, even outside of a sexual encounter.
Correct, yeah. So what can we do there?
Yep, and a risk factor for urinary tract infections too, because we need, a healthy external area around the urethra to protect from bacteria getting into the bladder. So that's very affected when you have these anatomical changes. So, there's a huge role for estrogen and hormonal therapies here. MHT can help, but it doesn't always kind of reach that area that's so, external on a woman's body, that some patients don't need the MHT component, or that's not enough. They can use vaginal estrogen, like a cream, and that's a whole separate treatment that does not come with the same risks as taking hormones orally. And
thank you for just saying that, because again, not everyone would know that MHT might be oral, right?
Yes,
whether it's a pill or a gel or a patch or some
correct,
form.
Yes, yeah. But essentially MHT is entering the entire body and bloodstream. So either through oral pills or through creams or transdermal methods.
So whole body versus localized intravaginal estrogen.
Yep.
And the risks are different. And I think a lot of people, me included, and even some primary caregivers aren't aware of this latest, the up-to-date recommendations, scientific and clinical studies. So that's, I think very key to go to your primary caregiver, right?
Yes.
So, and bring that up. And what happens if I go to my primary caregiver and I say, hey, I heard or read or Googled that, there's this thing, intravaginal therapy could help me. And it's not just my daily uncomfort. It's also painful encounters, intimate encounters with my partner. And I'm too young to feel this way. And I want to have intimacy. Okay. Yeah. And then my doctor or primary caregiver says, oh, what if they dismiss me? What do I do? What are things that you could help?
Yeah, what if
How
they
should
say,
I engage? What words can I use? Yeah, what happens if I get dismissed?
Yeah. They may be saying, oh, there's risk you might get breast cancer from that, or, hey, let's say your mother had breast cancer, so, this isn't a good treatment for you. Or honestly, that's a really tricky situation. I wish I had, an easy answer there, but the relationship between a patient and their primary care provider, it should be in a perfect world teamwork. So each team player brings, their own expertise. So for the patient, they bring the expertise of their own symptoms and what they're feeling on a day-to-day basis. They bring the expertise of their body and their experience. And the primary care provider or other medical provider should bring the medical side of the expertise. And ideally, through communication, you marry the two. So you're essentially describing a breakdown in communication where, one person's point is not getting across to the other person's point. So I'd encourage people, to use their conflict resolution, their communication skills. We don't need to escalate this into, conflict of me versus the medical world, the entire time, although I appreciate that it can feel like that for some patients, but use communication skills. So inquiry can be helpful. So, why do you say that? Why isn't that a good treatment for me? What have you read? Or, what's your understanding of that? Or, ask for more help, I think is never, never a bad way to go, of saying, I understand that might not be a great treatment, or you may not feel that's appropriate for me, but I'm suffering with this symptom. So what else can we do?
Yeah. I'm curious about this question, okay? And this is again, there's deep-rooted, perhaps, societal influences, but I find it interesting that in your later life, midlife, let's call it midlife, 40 plus, there has been, and I mean, there's studies, right? This is not me just saying that. There's a bunch of reports that have just come out in Canada, in the UK, and elsewhere, where this idea of dismissal or infantilizing a woman in perimenopause and menopause, when we say, well, I feel this, or I may need that. But in our younger years, there's a lot less questions asked for a whole bunch of medical treatments, not just birth control. That's one example where it's a lot quicker to be like, you need birth control? Here it is. But then all of a sudden there's more of a, what's the word? Misplaced protection?
Questioning, or
or what is it?
Yeah, more of a, like paternalizing approach.
Where do you think that comes from? And why in midlife?
That's a good question. I'd say from what I've seen in the healthcare system, there's paternalizing towards women at all stages of life. But you're right, possibly it's more pronounced, around this issue specifically. And that you could talk about as a whole big topic of, how do we fit in society, and how are we treated and viewed in society? And this is just one little, micro example of how that plays out. But this topic in particular is really tricky in the medical system and controversial because of some of the data that's been there. So, the medical system and doctors rely on, studies and research. And one of the big research projects that was around MHT was the Women's Health Initiative, which you may be familiar with, the WHI. For audience members who may not be familiar with it, I encourage you to look it up. But it was essentially this big, huge research study that, had recruited, I think, over 150,000 women. So, huge study. And it was trying to look at the effects of MHT on women's health. And they, when they got their initial results, they published these kind of very strong headlines of, we saw an increase in stroke, increase in breast cancer. We had to cancel the trial, because of these risks. So I think that was very widely publicized and is very present in the minds of, many people who practice medicine. And it's tricky once you put information out in the world, it's not so simple to take it back. You can't pull it back.
Yeah.
So that is a very specific kind of particularity of this particular treatment for this issue. Later, when they were kind of re-looking and reanalyzing the data, they found some issues with that trial. One being the age of the women was, older than your typical woman who comes in for menopausal symptoms. So I think their average age was early 60s.
Yeah.
Whereas women are typically coming in, their late 40s, early 50s, trying to get their symptoms addressed. And when they kind of analyzed the data a little better, they found that there was a whole bunch of kind of different issues and different ways you could view it. But a lot of the risk was in your much older women who are in their 70s. And some of the risk might be specific to the medications that were used in that trial. And you don't necessarily have to only use those medications. Right. But things get extrapolated. So they talked about the risk of progesterone a lot in that trial with stroke and breast cancer. And that is very specific to that specific progesterone they used in that trial.
Versus progesterone
But I see it in guidelines even now that they're talking about the risk with progesterone in general. So that's been kind of extrapolated out to other places.
And so what can our viewers do? And, these revised guidelines and studies that are now, I like to say segmented, right? They looked at the data again and they kind of paid attention. And so there are renewed or revised.
Yeah, and there's other trials that have gone on and other research for sure.
So where can our viewers go and educate themselves and then go to their primary caregiver? Because that's the key. You always have to go back. Nothing we discuss here, you have to go to your primary caregiver who understands your entire history.
Totally.
Right?
And like I said, not all symptoms are because of menopause, right? So,
but, what about the Canadian Menopause Society?
Yeah, so I think, an easy website to refer to, the North American Menopause Society, has some
I love that website.
Pretty great, patient-centered handouts that patients can kind of do their own reading and, approach their primary care doctor and say, hey, I'm having hot flashes and, here's a handout I read about some of the risks and, benefits and, I think this might be right for me.
It's a great website, and there's a section for primary care or clinicians, and then there's a section for patients or consumers. If you want to, we are consumers of our healthcare. So that's a great resource. What if you don't have a primary caregiver? And I cannot help myself but bring this because it's very topical in Canada right now.
Oh yeah,
it's not thousands. Am I right that it's millions of people? Where are we at? Yeah, we're in the millions of not having a primary. What do we do then?
Yes, millions.
What can someone do? This is whole healthcare sector thing, but here you are, and what do you do?
Ideally, a patient in a perfect world, patients would have a relationship with a doctor who can, follow them along for their symptoms. It's tricky in this episodic walk-in type scenario to, assess not just the symptoms of that moment, but over time, how are they improving or responding or not improving to treatments? So probably the patient's best bet in that case is to get a referral to a specialist like an OBGYN, because then at least, they may not have the primary healthcare provider. They could go to a walk-in clinic, see a primary provider there, get a referral, and although they don't have the long-term family doctor, they could still be followed by the OBGYN for the menopause-specific issues.
So it's deep, it's complex, it's not an overnight fix, but don't despair. Don't despair, and you can go to a walk-in clinic and ask for a referral to an OBGYN.
Absolutely.
So that's really good to know, because some people won't even know that. Yeah. We get discouraged or we're afraid.
Yeah,
we're afraid to push.
Yeah.
Afraid to ask.
Yes.
And so I hope that offers some help.
Yeah.
And then I feel like tackling the entire healthcare system is a bit too ambitious for this episode.
Probably.
But
that would be your, route of access.
That would be your route of access. So, Dr. K, I like to ask this question to all my guests. What makes you feel beautiful?
Thanks for asking. That's a nice question. For me, I think spending time with my family, my husband and my child, and I think engaging in moving my body. So yoga, exercise makes me feel, strong, capable, beautiful.
Well, I can say that just spending some time with you today, I feel that beauty, I see that beauty, and I feel your power. So thank you for taking the time out of your maternity leave with your beautiful new baby to come here and share your knowledge with us.
Happy to do it.
Thank you.
Thanks.
So with Dr. K, we referred to a book. It's called The Menopause Manifesto. It is written by Dr. Jen Gunter. She is a Canadian physician who now lives in California. She has also written other books. The Vagina Bible is another one. Amazing book. But today we're going to talk about the Menopause Manifesto. So what I'm going to do is just read a passage or two. If menopause were on Yelp, it would have 1-star rating. This establishment has temperature control issues. Drenching heat followed by terrible chills. Defies the laws of thermodynamics, would not recommend. Awful, awful, awful. Bleeding was scheduled, but was rebooked without notification, so arrived 3 weeks later than expected while I was in an Uber and I flooded the car. The driver gave me a terrible review. The sex was dry. I'm going to read another passage that really struck a nerve for me. Here it is. For women to navigate menopause, they need facts because empowerment requires accurate information. But they also need feminism because our bodies, our medical care, and even our thoughts have been colonized by the patriarchy. The cultural absence of menopause from our discussions isn't because that's what women want. The often pejorative language about menopause and the medical neglect also aren't up there on the Meno wish list. So if I've done nothing else on my podcast, but share some empowering tools that'll make you better informed about how your body works. You don't need to be a gynecologist to understand how your body works. This is what this book does for us. It is a call to action. It's much more than a manifesto.